morning, everyone, and welcome to today's Surviving the Unwinding Part 2. Before we get started, I want to just go through a couple of logistics. For those of you in the room, we are now joined by hundreds of people, of some of our hundreds of our colleagues out in the rest of the state. And despite the technology, they can't see you, we can't see them, but we're all sharing this space virtually and in person. It's sort of that new, not so new experience that we're having. So I am going to cover some logistics and some opening remarks. Restrooms, most importantly, down this hall to the right. There's also one there on the left. We will have drinks and boxed lunches at the break. And for those of you online, we'll be fielding questions and comments throughout the proceedings. So please use the Q&A feature at the bottom of your Zoom window for any questions or if you're having any tech issues. For those of you that might be new to UHF, I just want to let you know that we are an independent nonprofit focused on building a more equitable and effective healthcare delivery system for every New Yorker. And for decades, way back when we started in the late 1800s, we've been bringing people together to talk about challenging health issues in the city and state and how we as stakeholders can come together to bring solutions to these situations. And today is just one of those opportunities. Just to remind us all, we as a state have the daunting challenge of bringing 9 million folks along to make sure that they remained covered under either public or publicly available insurance. Back in February, when we first convened, it was clear that we all understood the magnitude and that we were committed to being partners with the state partners to make this happen. And a lot has happened since then. We are really excited to be hosting this today and learning more from our state partners about the progress that's been made. It's really exciting to see New York State at the forefront, but we want to do better. And so we are reconvening here today as promised, both in February and when we met in July for our Medicaid conference, where Amir presented some preliminary data. And now we are going to hopefully get some additional data and some early lessons learned and how together we can collaborate to ensure that we maximize the number of New Yorkers that remained covered. There's a lot to be done. We've got some great momentum early on that we want to continue, and we want to continue that promise that we made way back in February of being true partners. And being true partners mean that we celebrate the good stuff and that we come together to problem solve over the not so good stuff so that in the end, we can reach our mutual goal of ensuring that 9 million New Yorkers get the care that they need and that we focus on the people. So with that, I am very pleased to introduce Amir Bassiri, Medicaid Director and the man of the hour wherever he is. So welcome, Amir.
Thank you to Dr. Barbot and UHF. Really excited to be here today. As Dr. Barbot said, this is really intended to be an opportunity for us to both inform and hear from consumers and stakeholders and those on the ground. And that's really how we've structured today's stakeholder convening. We will share data. Sonia will go through all of the data, but we wanted to start and will start with hearing from on the ground stakeholders to hear what's working, what's not working. The data is going to be fluid. Every day the data will change. And this is something that I think everyone needs to accept and be willing to be flexible on, because this is both a national issue and in New York State. The numbers, how they're being reported, deviate. What we're giving to the federal government is different and than what we're reporting today and with EP. And generally, I think what we share with you is that point in time snapshot. Fortunately for New York, and part of our success has been driven by the integrated marketplace and some of the infrastructure that we've built since the ACA. You will see that in Sonia's detailed presentation. We are doing well thus far. We definitely are not, celebrating too much. The fall has the potential of being bumpy, but we are seeing coverage transitions and transitions specifically to ESI as expected in the urban projections and what we modeled out. So thus far, things are playing out as we expected. I want to be brief because we have a wonderful agenda and we have additional DOH staff who will be presenting today on the customer service efforts that we're making, as well as the on-the-ground assisters and hearing from them. So I will be brief and turn it over to Ann Volpel, who is going to start talking about customer service experience thus far and how we are doing so well as compared to what you may have seen elsewhere, which is not so good. So thank you for being here. We look forward to hearing feedback from stakeholders specifically. So please do ask questions. We really want to hear directly from you and know what we should be doing better. So thank you. Thanks, Jen.
Thanks, Amir. Just give us 1 second while we get Ann up. For those of you that don't know me, I'm Chad Shear, Senior Vice President for Program and Policy, and you will hear my voice embodied in the room and disembodied virtually today. So if you hear this voice, we're asking a question or switching panels. So Ann, I'll ask you to turn on your camera and unmute yourself and share your screen.
Thank you very much. And I'm sorry I couldn't be there in person. It's very difficult to follow the man of the hour, but I will do my best. So I'm going to talk with you today a little bit about how we're trying to support our consumers through the Unwind process. And to make it a little more interesting, I'm going to do it through the story of Z, who is enrolled through New York State of Health. And Z needs to renew their coverage by October 1st of 2023. So for that, our target renewal window would be August 16th through September 15th. So I'm going to walk you through a timeline of how we would engage with Z for this renewal process. So our first step, if you'll click, it would be the last week of July. We will send Z a get ready to renew email, and you can advance to the next change there. Okay, great. And that get ready to renew email contains a reminder about the renewal and also encourages Z to update their address with us, their contact information, because we know we want to make sure that that renewal gets to them. Okay, the next step in the process in the beginning of August, Z is going to receive their renewal notice from us by mail or email notification, and that would depend on what their contact preferences were in their New York State of Health account. And then our next step is on the second or third week of August, Z is going to receive a text reminder from us that the renewal notice was sent to them and it's time to take action. So we're hoping that with these reminders, Z has taken action to renew their coverage. But if in fact Z has gotten busy, been on vacation forgotten about it. We're going to take another step starting in September. And that first week of September, Z is going to receive an email reminder to renew and a text from us asking if they want help from customer service. And that text is going to ask if they want a phone call from customer service the next day between 9 a.m. and 5 p.m. To help them with processing the renewal. And then again, if Z has still not yet renewed, the second week of September, Z is going to receive another email reminder from us. And then finally, in late September, if Z does not respond to the previous text and still has not renewed, Z is going to receive another text from us asking if they want help from customer service. So we're doing a lot of outreach and reminding, and hopefully by October 1st, Z has renewed their coverage. So let's say Z did renew their coverage and needs to submit some documentation of their income. So we have a lot of ways that we engage with consumers, and one is through web chat. So if Z isn't sure what to do when it comes to submitting documentation, they can engage in a web chat with our customer service center to ask how to do that. And our web chat is designed to handle sort of general questions. We don't get into account specific issues on web chat because it's not secure, but general questions we're happy to answer. And then we would refer them to call us if they had a more specific account question. And then if Z did call us, or say we had done the renewal with them over the phone, we obviously could tell them how to submit documentation while we had them on the phone, but we would also offer to send them a text, and that text would include that information on how to submit documents. So we do that so that it's convenient for them. They have it handy for future reference in case they're not able to submit the documents immediately, or need to do it again in the future. The most common reasons that we text people this type of information is for document submission, as well as referral phone numbers. So if they called us up and they needed to call their health plan to get their question answered, we would offer to text them the health plan number so that the next time they needed to do it, they wouldn't need to call us back. And then the final way that we like to have people submit documents is through our mobile app. They can download our New York State of Health mobile app for free and use it to take pictures of their documents and submit them to us. Our mobile app has been very popular. In the month of July, 14% of our verification documents were submitted by mobile app. The most common method is obviously uploading them through the account on the web. But we've also found that our assisters are using it a lot for identity proofing documents. And in July, just to give you a flavor there, 62% of the identity proofing documents came through the mobile app. So I think it's been very popular for that. So we've been able to add some new mobile app features. We added these in the middle of July. So now consumers can log in and check their dates of coverage. They can confirm their health plan and the health plan's phone number. They can see a list of covered services, and they will get a little reminder pop up if it is time for them to renew their coverage. So we've had these features live for about 5.5 weeks, and we've found that over half of the consumers who have logged in do access that account information. And we've had over 30,000 page views of those screens. In the past month, 10,000 people have actually downloaded the mobile app, and we have over 254,000 downloads. And we have been promoting these new features through social media. So I think that has spurred some of that additional download. And we're excited to announce that we have some new features coming soon. Hopefully by the end of the year, people will be able to report to us a mailing address change. And they will also be able to see if they have any verification documents that are due and a list of what would be acceptable for them to submit to meet that verification document requirement. So we're excited about those additions to the features. Okay, and as you know, we've been doing a lot of outreach to consumers, asking them to update their contact information with us. It's been a feature of a lot of our advertising, keep in contact with us and make sure we know how to reach you when it is time to renew. If we find that we do not have a good mailing address for someone and their mail is returned without a forwarding address, and we have an email from them, we will send them an email. If we have a cell phone number for them, we'll send them a text. And we will also follow up with a phone call from customer service so that we can get good contact information for them so that they can stay in touch with us and maintain their coverage if they are still eligible. So that's been obviously one of the things we've needed to do in order to stay current with the requirements for multiple modalities from CMS. Okay, so how are we doing? Well, we have over 1,700 call reps answering New York State of Health phone lines, and you can click the first box on this one, Chad, thanks. It's about a 5 to 6 week training process. So it was a massive effort to hire all of these new folks and get them trained and get them on the phones and ready to take calls. And not only did we have to train the new folks who are coming in, the new employees, but we also had to remind the existing employees what the regular rules were because we were working under the PHE rules for 3 years. So some of the staff had done regular rules and then had to switch to the PHE rules, and now we're back to regular rules. And then others were hired during the PHE, so they had never really taken renewals as a regular course of action for Medicaid, CHIP, and EP. So, so we also had to get them familiar with the regular rules and the renewal process. So there was a lot of coordination, a lot of hard work getting ready for that. The next step, how are we doing here? Well, our staff now answer between 20 and 25,000 calls per day. And I'm pleased that we've been able to keep the wait times on average under 30 seconds. So we're very happy with that, and we hope that we're able to keep that going throughout the Unwind. Just to give you a flavor on call volume, last month, we had 88% more phone calls than we did last July. So it's certainly been a big increase in call volume during the Unwind, as we expected. And we're doing everything we can to try to support our sisters as quickly as we can for things like dashboard changes so that they can continue to help the consumer while the person's there in front of them or on the phone with them. Because we know it really is going to take everybody doing their part to make this a success. The next box is on document processing. So we obviously are trying to do as many ex parte renewals as we can. So that would reduce the number of documents that are required for renewing coverage. But when people do have to submit them, we've been able to get them processed in 1, 2, 3 days. It's been very efficient. Our next box is about language access. And we have over 500 customer service reps that offer service in more than one language. So if a consumer calls and they need help in Spanish, Mandarin, Russian, Cantonese, or Haitian Creole, it's likely that we're going to have a rep who's able to serve them in their language without the use of the language line, which obviously is a much easier experience for the consumer, much more pleasant, a lot faster. So we're pleased to have them on board. And again, to give you sort of a flavor as to how that has been helpful, in July, we had 116,000 phone calls that were handled in a language other than English. That's about 28% of our call volume, but only 12% required the use of the language line. So it's there when we need it, but we're pleased that we have so many staff who can speak multiple languages and assist consumers in their language of choice directly. And then finally, texting is one of the newer things that we've been offering lately. But we've been found that people have responded very well to our texts. Our call center reports that call volume goes up whenever we do a texting campaign. So they're seeing those texts and people are calling us and responding. And then those texts that I described earlier, where we offer to call the person the next day if they want help renewing their coverage, we found that 10% will respond asking for a phone call the next day. And when we make those calls the next day, 50% of the consumers, we're able to connect with 50% of the consumers when we call them. And that doesn't count the folks who might not be able to pick up the phone at the time that we made the phone call and they call us back later. So we're really pleased with that connection rate. In real numbers, it's probably about 2,000 each time, which seems like small potatoes. And those, again, are just the ones that we connect with, that 50% that we connect with when we make the phone call. But I always say that it's 2,000 fewer appeals that we have to deal with, 2,000 fewer consumers who might have to experience a gap in coverage. So we think it's been a very successful effort and we're very pleased with the results there. And when we do call people about those address updates, we usually reach them about 20% of the time. So that's been pretty good too, trying to make sure that we maintain good addresses for folks so that we can contact them when we need to. So that just gives you a flavor of what we've been doing on the customer service side to support our consumers through the Unwind process. And I'm happy to answer any questions.
Thank you, Anne. We have a roaming mic in the audience for questions. We've got about 10 minutes right now and then a fair amount of time available this afternoon. I am going to make Anne a little bigger here now that she is done with her slides and we can see her a little bit better. And Emily's got one in back as well. You gotta hit the green button on the bottom on that one as well. Couple of questions, a ton of questions already from online, some of which we'll get to now and some of which will probably be in the discussion this afternoon. And can you clarify, this process is not just specific to health exchange enrollees, this is for all renewals coming through the New York State of Health Marketplace, not just QHP?
Correct. Oh, yes. Yeah, these efforts are for all programs through New York State of Health. Yes.
Peter, Emily have audience mics. Got one over here. Oh, there's one back there. Peter, you want to go over here? Yep.
Good morning, everyone. It's good to see familiar faces here. I'm Mahatia, New York State of Health Navigator. I'm proud of it at the Arab American Family Support Center. I just want to say thank you for the services we provide and the help and support we always get from New York State of Health. And when we call on the hotline number, I just want to let you know you have a great presentation and great staff out there, very good knowledge, and they respond to our request all the time. And the ID proofing is great, working great with us. And the language access, because I deal with the Arab American community, the response, they have to use the language line. But they're doing great with it. The dialogue sometimes is very difficult for our clients to understand because we have 22 countries and each one have different dialogue. I just want to put you on the spot to see what's on the ground, what's happening with us. The unwinding, it's killing us. I'm trying to process 100 applications a month. So we're doing a great job. I could say 10% of the unwinding applications, people because of COVID, they moved out of the state, they changed their addresses, they changed their numbers. Well, we can't reach them. But you could say 90% of the application we're trying to process as much as we can. But I just want to thank your staff on the other line when they respond and they are good responders. Thank you.
Well, thank you very much. I will be sure to pass that along to our customer service center. Thank you.
Hi, it's Priya Mendon from BNSL. Thanks so much for your presentation and 25,000 calls a day, I think you said, under 30 seconds is amazing, and that number is very daunting. A question for you is, what are some of the top trends you're seeing in terms of the inquiries that are coming in? And are there certain demographics, parts of the state where you're seeing, more calls coming in from callers, and what can help us do to assist to minimize and reduce that call volume?
So I think I caught most of that question. So call trends, it's largely been about renewing. When do I renew? Why do I have to renew? I haven't had to do this recently. What is all this hype about? People sort of just either confused about the process. Again, some of them have never been through a renewal before. So it's not, it's different for them. So trying to explain that to them, reassure them if they don't need to renew until next year, that they didn't have to do it, but we can obviously go ahead and make changes if they want to. And so that's really sort of been the call, the top trends. And obviously we're doing a lot of outreach. So a lot of the phone calls are a result of all of the outreach that we're doing related to updating your address or processing your renewals. I can't say that I know off the top of my head the areas of the state. I believe we have some of that data. That's not something I know off the top of my head as to who's using the customer service center the most compared to other areas of the state. But I certainly could go back and take a look at that.
Question from the Zoom, curious about the trainings and how it's broken up between classroom or any shadowing. And is the training just for new hires, or have you done refreshers for older employees as well?
Oh, absolutely doing refreshers. We always have refreshers going on. I believe we do a combination of Zoom and in-class training, sort of depending upon what the topic is, whether it's a refresher, how confusing something new might be. As you all know, we're always adding things to New York State of Health. So we always have to train people on new features in the product. And so some of those might be sort of self-study, and some of those would be Zoom, and some would be in classroom. So it really sort of depends on the topic and the training group. Shadowing, I'm glad you mentioned that. We actually went through a process during the public health emergency to evaluate why people were not staying with the job and what we could do to better support customer service representatives as they start answering calls. And the feedback that we got from customer service reps was that they really wanted to understand the job earlier in the training process. So we sort of revamped the training so that we offer the job shadowing portion sort of earlier in the process and throughout the training. So you might learn about a concept or a process and then have the opportunity to shadow for a little bit to understand how that's applied. And then we'll build on that in the next segment and teach them something else. And then again, give them the opportunity to practice that or shadow it for a little bit. So that's been a really great addition, and we think has contributed to the good employees.
Great. Last question here in the room, and then we'll move on. But all these questions we'll get to the state, and we'll have a big discussion period this afternoon where we may tackle some of these issues.
Good morning. My name is Roger Miller with Metro Plus, and I, like most of the people in the room, would like to say what a wonderful job you guys are doing. I've been here since the start of the ACA, and so I remember the long waits when staff used to call. I do not hear any of that now, so you guys are doing a phenomenal job with that wait time. We really appreciate it. Question, not trying to add more to your plate, but there's a demand for longer hours for the call center to be open on Saturdays, because some of us have staff that work way past 1 o'clock on Saturdays when I know the call center closes. And we find that there are surges during certain times of the month where Sundays, I know we put in our request for Sundays as well, but is that a possibility to add additional time on Saturdays and to potentially have at least one Sunday, particularly after the list drops each month, so that we can do a better job in helping people be certified?
Thank you. Thanks for that feedback. And again, for the kudos, we appreciate that. We're always looking at various opportunities to make sure that we can provide service and be open to make sure people can get renewals. So we'll certainly, we can take that back and look at it again and see if that's something that we think would be well utilized. Right now, our Saturday hours, we don't get as much, certainly not as much activity as we do during the week, to be perfectly honest with you. So it's not a highly utilized time, but I know it's more convenient for some people. And, so we certainly want to make sure that we've got, some hours on the weekends for folks. So thank you.
Anne, thank you so much. Please join me in thanking Anne and the entire customer service team at the marketplace. While Gabby and the panelists come up, I'll ask Anne to turn off her video. She will be around for the rest of the day too, so she can disembodiedly answer questions later in the day.
Good morning, everyone. My name is Gabrielle Armenia. For those of you who don't know me, I wear two hats at the department. I am the director of the Child Health Plus program and also direct our application assister programs. So thank you for this opportunity today. I think we have a lot of good feedback that will help us all learn and how much work is being done on the ground to help with the unwind. So for just as a little background, New York has had a very robust consumer assistance program, even pre-ACA. A lot of my colleagues here have been working, their agencies have been working on this kind of activity for over 20 years. So we're so grateful to have that community and support and partnership. And I think it's a testament to how well things are going so far. So just again, as a little background, as of July, we have over 5,300 application assisters throughout the state. This includes four different types. We have our navigators, which is our grant funded program. We have certified application counselors, which were traditionally provider groups, hospitals, FQHCs, other community-based organizations. And then the biggest group is our marketplace facilitated enrollers, which are health plan assisters, which they all are doing the same work on the marketplace, but just, different sources of their employment. We also have a smaller group of application assisters that work with local districts for the age, blind, and disabled population. These folks, as I said, 5,300 plus, are available in 66 languages, are at all different areas in the community, so they can, be where people need them. With COVID, we've done a lot of shifting to phone assistance because that was what we had to do, but we found that it's been a very successful way to continue to outreach and work with consumers. So I'm just going to start with just a few things that we've done to prepare our assisters for the unwind, and then we'll get to asking our panelists some questions that will hopefully be helpful to all of you. So we began by having a two-part training held in April. Part one was focused on what the rules were of renewal, because again, a lot of people haven't had to renew before. A lot of assisters haven't had to go through a renewal before. So it was a refresher on the rules. Part two of the training was to go through the outreach and ad campaign that the department was working through, as well as going through the assister dashboard and the assister oversight manager dashboard, again, to refresh assisters on tools that are available for them that will help with the renewal process. We held an additional training in June to go through some new features that we added to New York State of Health to make renewal easier and hopefully more successful. This included like going through the late renewal process that we added for CHIP and EP, which I think has been a great help. As Ann mentioned, we repurposed one of our existing lines, which was used for our navigators, for assisters to make what we're calling quick calls. So basically, if a consumer wants to switch and have somebody else help them with their application, they can call this number rather than waiting in the call center queue. And they do a few other things, but we think that's been successful so far and hopefully reducing wait times on both ends. We've also tried to anticipate the types of reports our assisters would need, and we continue to revamp this. During the public health emergency, we were sending reports to assisters of consumers they had helped in the past who had returned mail, and that was essentially a returned enrollment notice. We've basically modified that a little bit to include both the enrollment notice and the renewal notice, so you have a good sense of who to do outreach to try to update an address. We also, through the assister dashboard, assisters can produce lists of who they've helped in the past who are due to renew. They can break that list down by, you know, who's due to renew in 45 days. If they want to go ahead, who's due to renew in 60 days. And the assister oversight manager functionality, where a supervisor of a bunch of assisters can do the same across the people they supervise. And one last thing that we just started doing, which we've been, I think it's our second month, we pull a list of consumers that did not complete the renewal in time. So basically, you know, if you didn't get your renewal in by August 15th, we're sending out a report at the end of August. So you have that 1 month where you can do a last ditch effort to try to get someone in where they can have the renewal late, where they still don't have a gap in coverage. We also send email blasts, post various resources, and have an assister newsletter. So, you know, we're always open to trying to determine what else would be helpful. So if any of the assisters, you know, have any suggestions, we're always open to that. But I think the most important part of today is our panelists that are going to help us understand the work that they're doing. And I think you're going to find that based on the type of organization and the programs they help with, everybody's doing things a little bit differently. But we try to pull across sections so we could give you a flavor of different pieces. So I'm going to start. We have Jennifer Chu from Health First, assistant. I don't know if I said your name right. Sorry if I didn't. Assistant Vice President of Medicaid Growth and Retention. So Jennifer represents a health plan assister. Next to me, I have Francine Bowe and Pamela Ramperswad, who are in the patient services, patient financial services at Montefiore Medical Center. Again, a little bit different approach that they're taking, which I think is very helpful. I have Michelle Honan, and on virtual, we have Wen, who are with Public Health Solutions. Public Health Solutions has been an assister probably for 20 plus years. And in addition to being one of our navigator agencies, they also work on our facilitated enrollment for the age blind and disabled. And last but not least, we have Chad Eldred. He's also virtual. He is from the Southern Tier Independence Center, also a navigator agency and a subcontractor for our FE for the age blind and disabled program. So Chad, I think, will be helpful in giving more of an upstate flavor and how the differences with a rural population versus a more urban population. So I'm just going to start by posing some questions to our group. We'll kind of take turns going through them. So I think I'm going to just start by going down this way, and then we'll go to Chad, and then we'll just take turns. So I guess the first thing we'd like to do is talk about your approach to how you're reaching out to consumers. Are you doing proactive outreach? And if you are, how are you doing that outreach? So I'll start with Jen.
Absolutely. So at Health First, we have an omnichannel approach. So it's really not just direct mail, but it's email, an SMS as well, and our sisters are doing personalized call outreaches as well. So the main way that they've been outreaching to members is using the New York State of Health Sister Dashboard, looking at which members are up for renewal and then documenting those outreaches. So if they're unable to reach, say, an individual in the morning, they're going to try in the afternoon, right? We meet that individual where they are. So, if they want to renew over the telephone, they could. If they want us to meet in person, we have our 26 local community offices, as well as mobile units, so they can meet us in person on the ground. We also help individuals at our community events as well. And, with all of this, our omni-channel approach, we are pleased to, report that we do see a positive trend in our renewals for our June and July cohorts.
Sure.
So yeah, we're also doing a multi-prong approach to reaching consumers and doing some proactive outreach, extensive outreach. So we're sending first we're sending text messages to those who we have consent for, and also postcards based on their coverage end date. And it kind of the messaging has like a call to action to contact our sister, and also available in the language that the consumer speaks. So we have that information in our database, and we try to make sure that we're sending that out in the appropriate language. And the postcard has 4 different languages on it. And one thing about the text messages that has been really successful is that we've been personalizing them to the sister that they worked for, so that the consumer recognizes the person that we're asking them to contact. So it's not just a robo text message saying to call Public Health Solutions, but you worked with Joni in the past, like, please contact us or let us know if you'd like us to follow up. And then if they do reply to the text message, we forward those to the navigators to do proactive outreach to call the consumer. And then we're also using the list that Gabby mentioned and doing proactive outreach to the undelivered mail list and the list of consumers who failed to renew. So we divide those up from the assisters, and they call who's ever on their dashboard. And we do 3 attempts at different times a day, similarly to what you mentioned. And if that's not successful, we have an email on file, then we'll also email them a follow-up email. And if the phone number isn't working for some reason, then we'll just send an email immediately to kind of have that multi-prong approach. We're also working on an email campaign more generally, and a digital media campaign, and sending all of our sisters to events in the communities, whether that's in partnership with the New York State of Health, or just events that we have locally to kind of spread awareness of everything. And overall, it's been pretty successful. The navigators are super busy. They're getting a lot of calls, and they're reaching a lot of their clients.
Great. Is there anything different you would say about the age blind and disabled population?
Yeah, so we're doing the same kind of mediums like text message, postcard, calling, and the email, but we can't really rely on the same data because New York State of Health has everyone on the dashboard, but for our ABD program, we have just a separate database that we rely on. So, that's kind of a little bit different. And there's not as much advertising out there about the ABD program because, the New York State of Health has been doing this big media campaign, but it's just not as extensive. So there's a lot more like education required, I would say, like one-on-one education about documentation requirements, which are also more complicated for that application. And just kind of making sure that they're looking out for their renewal packet, which they're going to get in the mail from HRA. So sometimes people aren't getting their renewal packet. So it's kind of like a little bit more making sure that the process is running smoothly. So, it's a different process, but it's the same overall approach.
Yeah, great. Thank you very much. So Francine and Pam, I think Montefiore, it's a little bit different, but I think you guys have done a lot to reach people. So.
Yeah, so we also have our sisters work off their dashboard, send letters and phone calls. We've also, off of our Epic system, ran reports where we have the restart date on the eligibility, which we also have done mass text messaging.
So can I just interrupt? Is the Epic system the intake system at the hospital?
Yeah, that's registration and billing altogether. The other, we also continue to educate our own staff because they can kind of get lost in the whole process. So we have huddles every day, weekly meetings, monthly meetings as well, to keep them in the loop of the results, and what's going, how, if it's working, it's not working. And it has been successful so far. So that's where we're at now.
Great, thank you. And last but not least, Chad. Hi.
Hello. So in addition to a lot of the things that have already been mentioned, I would like to think that this effort actually began long before the Unwind. It went on through the pandemic. I think we all knew this day was coming. I'm very fortunate in that my direct team and even our subcontractor teams have been around a long time. They're very familiar with their dashboards. They're very familiar and have strong relationships with the people on those dashboards. And throughout the public health emergency and all this uncertainty, we've been able to act as a source of support for them and to kind of cut through the noise and to help support them with, having an idea of what this might look like and when this day would come. Now, clearly, everyone is on a spectrum. Some people would call us on a regular basis and we'd have ongoing conversations. There are others that are a little tougher to find. I think it was helpful that throughout the pandemic, we did use some of that time to work on things like updating addresses and contact information in order to give us the tools that we have now to reach out to people and try to prevent as many people from falling through the cracks as possible. But I think that leveraging the ongoing relationships and trusting my team in knowing how to support the people on their dashboard has worked pretty well thus far. And Gabby, you had mentioned that we are definitely in a little bit of a different situation here upstate. I think we have to rely a little bit more on low tech. A lot of the people that came to us originally came to us because they maybe weren't comfortable with uploading documents, doing things on their phone, et cetera, and trying our best to mitigate those issues, which includes the things that we've always done, which is to meet people wherever they need, to equip our staff to be mobile, whether that be to have the capability to scan documents or what have you. So it's really an all of the above approach. One other thing I would mention that I think has been a strength is that New York State of Health in the arc of their existence has kept their branding pretty much similar. It's very difficult to cut through the noise. And the fact that people have become familiar with the mailings that come out from New York State of Health. I know that the people that I've enrolled over the years and I instruct my team is when you see that logo, if you want us to help you interpret that document, go ahead and give us a call. We can see, navigators can see the same mailing in the account and pull that PDF up and really add value to the person by helping them interpret that to understand their dates and their timelines.
Great, thank you, Chad. That was really helpful. So our next question, Michelle, I'm going to start with you. When your sisters do this proactive outreach, are consumers aware that they need to renew? Are they surprised? Do they not understand? It's probably like a spectrum of all of that, but what are you seeing?
We're seeing that the majority of clients are aware. We kind of got some feedback from our staff, and about like 80 to 85% of the clients that we reach out to are aware of their need to renew. They've either gotten a notice from the New York State of Health or a text message or email from them, and also heard from their health plans. And beyond that, there's just like a lot of buzz in the community from their friends, family members, coworkers, and like ads on the subway and whatnot. Like there's just a lot of, I think the media campaign's been really successful. There's a lot of education out there about the need to renew. So the majority of them have heard about the need to renew. There's some people that are unaware, and in those cases, it's usually because they maybe changed their address or phone number, so they didn't get the notices. So we always have trouble with that group that are hard to reach.
Gwen, anything you'd like to add? I forgot about one before.
Sure, I think Michelle kind of touched on the Navigator program. I think I can talk a little bit on the ABD program. So majority of our, I would say most of our ABD clients are aware of the renewal requirement and have a general ideas of what documentation they need to provide. Some senior have, for some senior, we see that if they have not received the renewal package, they actually contacting the HRA hotline to request one. And some senior, we know that they have been informed about the auto renewal because they have SNAP benefits. And there are some senior, they have come to us because they actually return the renewal package, but
receive a deferral notice from HRA requesting additional information. But we are letting them know that the COVID, they are getting a 4 months additional extension from HRA, so they will have more time to submit those documentation back to them. And we also have some seniors that they prefer to go to HRA directly, which we just provide the address, to them.
We're a little different here. When the patient come into us, they're not aware that they need to renew. They automatically assume that the renewal are being done automatically. So we reach out to them, we send appointment. Before we do the appointment, we run a report, and we have the patient that's with the AOM. We recently signed up for that reporting system, which is new to me still, or new to us still. So we reach out to them based on that. The ones that said auto renew, we skip, we go to the manual, we call them. And when we call them, we have to explain the whole 9 yards, what needed to be done. And also we have another program that when the patient make appointment to see the doctors or the clinic or in the ED, we check the coverage in Epic or TC, real-time eligibility, if there's a pop-up that tell us that the patient needs to renew their coverages.
Thank you. That, anything different that you'd like to share? Are clients aware of their renewal?
Gosh, we're back to me already.
Yeah.
Yeah, I think that, and to speak in general terms, I think they kind of fall into two camps. The people that had been in programs like Medicaid and the Essential Plan prior to the pandemic were accustomed to the renewal process, and they may not have heard that it's coming back, but they're not necessarily stunned when they find out that they have to renew. And then there's actually a significant number of people, I think we all kind of lose track of the amount of time that we lost in the pandemic, that may have, for the first time in their lives, had a child or themselves on a program that needed to renew and had no idea that that was the default setting, that we were going to go back to a world where they had to renew. And that's kind of like explaining it to them from square one. I have a coworker here who, her son was born in late 2019, has never had to renew. So she's doing it now for the first time. And I think that that's something that we just, and I should not say we, but we've lost sight of, is the fact that, that we lost so much time. There's a significant cohort of people that have never had to go through this process.
And Jen?
Yeah, I'll just add to that and, really thank the state that the, awareness campaign has been so robust on email, social media, and, the communications toolkit has been wonderful. We've been using that and building upon it. So, same thing as we find that most folks are actually aware. And then the folks that are unaware, like Chad, it's different between someone who's renewed before versus someone who's renewing for the first time. We do think that there's, additional opportunities for those subset of folks, make them more aware. Maybe it's something like an additional touch point, maybe 3 to 6 in advance of, their renewal window opening, just giving them more time to prepare for it. Or maybe something like, having the direct mailer like stand out a little bit more among all the different mail pieces they get. Those are just, some of the ideas we're thinking about for that subset of members who are unaware.
Okay. So next question, I'll start with Francine. So are you hearing from people that you didn't help in the past? And again, I feel like your situation may be different because you may have people that are at a facility and might find out they need to renew. But if you are hearing from people that you weren't the original helper, how are those coming through? Are they coming through the call center? Are they being referred from some other source? Or
so we have had a lot of walk-ins that have asked for assistance, and we had asked, well, how did you get here? Why would you come here? And so we have signage all over our registration areas, our clinics, our EDs. So a lot of them mentioned that they had seen, and it'll state all our locations because we have locations all across the Bronx. They've gotten the information from there. We've also put the marketplace number there on those, on the signage. So they've mentioned signage, a lot of them. So that's where we believe, we think that that's a helpful tool. the
Great.
Signage.
Great. And just to add to that too, when the patients are admitted and they don't have coverage, we reach out to them to assist them. Great, yep.
Chad, you're up again.
Yeah, we definitely have a lot of people that are coming to us that we haven't served before. And, you know, once again, it was a long time. So whomever helped them before may not be around anymore. And I don't mean that they're not on this earth. I just mean they may have gone to a different position or job, work for a new company. So there's definitely a lot of that. In most of the ways that they find out about us are, you know, for us, it's still the tried and true. It's either organizations that we've created, like NGOs we've created longstanding relationships with, or people that we've served in the past. I don't know how it is downstate, upstate. There's still a lot of informal communication channels, and people are going to trust the person that they saw at their, you know, their neighbor or Sunday dinner, and they're going to tell you that this is the person you need to go see. So we really rely on that reputation being spread by the people we've already served to kind of get the word out.
Yeah, so, you know, absolutely, individuals who've had a really good experience with our sisters tell their friends and family about it. So we hear a lot from them as well that we haven't helped in the past. There's also individuals who just go on the New York State portal and want to find someone who speaks their language. We've been fortunate enough that our sisters speak a variety of different languages, you know, English, Spanish, Hindi, all ranging even to French Creole. So we hear from those individuals as well. And, you know, for us, our stance is we're here to help, we're here to educate members, and we'll direct them to the right resources to help them.
And Michelle and Wynn, anything additional you'd like to say about public health?
Yeah, I mean, we have a similar experience. We're definitely getting a lot of calls and walk-ins at our sites. Some of the places that they hear from us, the ad campaigns, like I mentioned, we have a similar experience with word of mouth from friends, relatives. They tell, we're known in the community, you know, they tell their friends about us to come, you know, that they need to renew their insurance, they can contact us. We also get a good amount of referrals from the New York State of Health line that they send to us, and sometimes from health plans specifically for ABD. We get a lot of referrals from health plans because we can support those applications directly to HRA and from like Medicare brokers. And the HRA info line actually has been giving out our number too. So we do get a lot of calls from that as well.
Great. When anything else to add on that, or?
I just want to add that during the summertime, we have been invited into attend a lot of community outreach events. So that has been also a very useful source to kind of promote the you know and provide education on unwinding process. And I think for you know through the outreach event, we actually able to reach both population, the people under 65, and then also our age-blind and disabled population as well. So that has been working really good too.
Thank you. Chad, we're going to start this next one with you. So for the consumers that you're trying to reach, or you do successfully reach, who decide they don't want to renew, just anecdotally, what are the reasons they're telling you? Are people saying like, I'd rather do it by myself, or, oh, I got a job that now I have other insurance, so I don't need to renew, or any other reasons? Are you seeing any patterns with that?
Yeah, I mean, we always get a few people that'll call, just ask some questions and then go ahead and do it themselves. And, you know, that's fine. I've always considered that part of the navigator role. It's not necessarily to funnel them through our services, but just give them the tools that they need to feel comfortable and get things done. Education's a big component of what we do. I tell people on the first day that we meet them, we're a partnership as long as you need us to be a partnership and you're in charge of it. Based on that, I think it does develop a bit of trust when you phrase it that way. And that's not my intent. It's not some reverse psychology ploy, but most people will tend to come back to you because they feel comfortable and they like that added assurance. But there are those that do it on their own. When you bring up the employer sponsored coverage, That's a conversation that we do find ourselves having quite a bit right now. And it's with, I can just give an anecdotal example that is generalizable, but it's a person that may be making a substantial amount of money right now because at one point during the pandemic, they lost their job and had Medicaid or essential plan or whatever for a brief period of time. And now they have employer sponsored coverage. And when their renewal comes up, if it's an automatic renewal, suddenly they're looking at a QHP and they're staring at those prices saying, what on earth is this? That's when we get a call, is when somebody gets alarmed or scared. And they're not necessarily aware, especially younger people, that they're entitled to a special enrollment period at work. And then they're looking at that as an option. And those people I tend not to hear back from, because oftentimes the employer sponsored coverage is a little bit better deal than, you know, a QHP.
Are you finding the same or?
Yeah, absolutely. I think that during the pandemic, it has forced folks to, do things a little bit more digitally. So we do see more of that, of folks wanting to renew on their own, or wanting to renew with the New York State of Health directly. Of course, like Chad said, employer sponsored coverage, we're hearing that. Or, what we've heard is people moving out of the service area or our coverage area. So they no longer need coverage here. There's a variety of other reasons, but whatever the reason is, we are outreaching to all of our members just to make sure that they have an option for them to ensure no gap in coverage.
Michelle?
And when?
I don't want to forget you when. I'm sorry.
Yeah, so we have a similar experience. We have a lot of people that have moved out of the state. They just don't need our assistance, or, maybe they haven't heard from us in a while, or they don't really remember that they worked with us in the past. So they prefer to go to a sister closer to their home. But we've also seen the issue with the employer spot, or not issue, but a lot of people have gained employer sponsored coverage. They just no longer need coverage, but sometimes they don't want to take the time to kind of update their account, which can cause some issues, because then they keep getting reached out to, and it's like they don't need coverage anymore. And then one other group that we wanted to mention is just that there's some clients that are not eligible for Medicaid or essential plan anymore, and they just don't want to pay for the qualified health plan premium. So, maybe they don't have employer sponsored coverage, but they just don't want to have insurance because they don't want to pay for that premium. It's not a huge group of people, but definitely exists out there. And again, some people want to just do it themselves. And for ABD, it's kind of similar. We mainly, we have two ways that we support people with ABD renewals. One, we submit through their electronic edit system, but we can only do that with the community coverage referrals. So we have to help manually with the long-term care referrals. So it's just kind of a different process. So sometimes they just prefer to drop it off themselves or work directly with HRA. And then again, a lot of ABD clients are getting auto renewed through SNAP. So, yeah.
Gabby,
Thing to add.
can I add one more thing?
Sure.
Sometimes those people who do it themselves, they do, and I'm sure the others have experienced this as well, they do boomerang back to you. They hit some sort of snag in the application and suddenly it didn't go as swimmingly as they thought it would. And that's fine. Again, we're a partnership as much as they need it to be.
Thank you. When, anything else you'd like to add?
No, like everybody mentioned, we basically seen, having a similar experience.
Thank you. Yeah, so I think one of the challenges is capturing the people with the ESI, because people don't want to go in and update their application when they don't need the coverage anymore. So we're working on different ways to quantify that. Okay. So I'm going to go back to start with Jen. Are you seeing any specific barriers to renewing people? Is language, I know Health First has a lot of languages your sister speak, but are you seeing any barriers to the process?
Absolutely. So, like you said, we have sisters that speak a variety of different languages. What we are finding is that a lot of our individuals don't understand the material that's in there. It's not at their reading level, right? I think of a family friend of mine whose main language is Arabic, and she doesn't know what renewal or recertification means, these words that are kind of used interchangeably in the news. But she knows, hey, I have to do this or, I'm going to lose my healthcare coverage, right? So we've been directing members to us to, help them walk them through the process in their language, right? The other piece is some of the challenges, the dual population, right? Helping them navigate that process, whether it's on the New York State of Health or say through their local Department of Social Services. So that's a bit of a special population. We've also heard of phone scams. So folks are, it's a very vulnerable population. Folks are hesitant to give their personal information over the phone. We understand that. So we're directing folks to the State of Health directly to renew, or meet with us in person to alleviate their fears. And then specific to that population that renews the paper renewal, say through their local Department of Social Services, we love that, there's an option this year of the Access HRA app and website for them to do it online. That's great. They can do it from the comfort of their own home. We want to make sure that more folks are aware of that option. The other piece is we know these folks, are being auto renewed, say for SNAP due to the many waivers. We love the waivers. We hope they continue, right? Or they're getting extensions. They have more time to renew, which is great. We just want to make sure that we receive this information timely so we can better educate our members and say, hey, don't worry about it. You're auto renewed for this year, or hey, you actually have more time. So those are just some of the challenges and barriers we're working through, to make sure that folks don't lose that coverage.
Yeah, so we sometimes, see some language barriers, specifically if it's a language that one of our sisters doesn't speak in the community and they have to use like the language line feature on the call center. That can be a little bit complicated sometimes. And some of our navigators have expressed that that's a little bit of a challenge. In general, the wait times have been pretty good, but there's, still some wait times on the navigator line. And then we just sometimes, especially with the ABD consumers, they're just like really confused when they get the package in the mail. They don't know what to do, so we've had to spend a good amount of time just explaining the process, and especially the documentation requirements. A lot of the media and stuff that's going out, they don't really mention the documentation requirements, and they can be pretty complicated and confusing, especially if you don't speak English as your first language, and it's just a very complicated process, particularly for the age blind and disabled process. So I guess some more messaging around like the documentation that's needed was one, idea we had that might be able to help with that. When, anything to add, Wen?
I think there's one thing that I received is a lot from the staff in the field. It's related to they mentioned that there's a lot of clients being misinformed or educated on their eligibility, especially the population with no immigration proof, but only with their foreign passport. So they say son and sister have been helping this client enroll into EP by selecting immigration non-citizen as their immigration status instead of other in the application. So therefore, the client was enrolled in a 3-month temporary coverage in essential plan, and also not informing the client that they need to provide proof of immigration proof. So this is creating a lot of challenging for our staff, assistant in the field when they're assisting this population, this client, because they are questioning us like why other places can enroll them into EP, but you can only enroll me to get me into emergency Medicaid. So this has been come out a lot from the field staff. So we wanted to that I think that will be also like a challenging in terms of maybe letting a little bit of education material on educating those people, if they don't have a legal document, what potentially other program that might be available in the community to help them.
Okay, thank you.
For Montefiore, we're a little bit different again. Because during the summer, a lot of our staff is on vacation, they called out. So we find that to be during the June, July, August period. It was very challenging for us because of the short staff. And when the patient comes in, they're on the domicile and we don't have no picture ID, we can't identify who they are. They're giving us one version of what they're telling us, then they're being interviewed by the social worker, they're given another version. So it can be a little bit complicated for us. And also, they don't have an address. So when we try to put it, ID prove it through the marketplace and do it. So that seems to be one of our challenges that we've been experiencing, a few of them during the summer period. And we do have an interpreter service that we use. We find that to be very helpful. But as we call them hospital hoppers, they go from one hospital to another, change their identity, and yes, it can be very challenging for us.
Thank you. And Chad, anything to add? Chad?
All right, sorry, suddenly I couldn't find my unmute button. I mean, as far as barriers, I kind of go back to the thing that I think is most difficult is just cutting through the noise of information. We just have so much information being thrown at people right now. I mean, if you go on, just watch TV and see the things that are targeted at people regarding healthcare, whether it be Medicare products or long-term care insurance. And it's just to people who don't swim in these waters every day, it's all just noise. And it's tough cutting through that. And it's tough establishing trust because there are so many people out there looking to take your money. For every one of these products that's authentic, there's 2 or 3 more that aren't authentic, and they're getting phone calls for these things day in and day out, especially for people who have landlines. And up here in the rural areas, there's still a lot of people with landlines. So getting the correct message to people, I think, is the biggest barrier that we have. And the way that we've mitigated that is I go back to the relationships that we've built over time. That's invaluable to people who are having a hard time sifting through all the noise.
So we're almost out of time, but our last question was there anything else you'd like to share? Any strategies you'd like to share? I think you've all kind of explained what you're doing, which is great. Or any ideas for any future things that we could do to be helpful as we continue for the additional period of the unwind. So I'll start with you, if that's okay.
Yeah, sure. I think we kind of talked about our general strategy. One thing we've just found really effective is the text campaign, and specifically the personalized text that I mentioned before, making sure the communication's in the right language and that there's kind of a call to action. And then just finally that there's like multiple touch points, which I think has been going on, but it's like if you miss the text or the call, you'll get an email or a postcard. So hopefully one of those messages will meet you. Also, we're going to be trying a digital media campaign for like the younger population that might not want to renew because they're young and healthy, and maybe they were eligible for Medicaid before because they lost their job, but they're now moving to a qualified health plan. So we'll see how that goes. And for ABD, we think one strategy we want to work on is kind of working more closely with the providers so that they can provide information, to the seniors about their renewal, since that's kind of like a really trusted resource for them that they see regularly.
Good ideas. Gwen, anything from you to add?
I think this is also mentioned earlier. If we have more information on documentation requirement on the outreach message, that will be also very helpful.
Okay. Francine or Pam?
I think that our signage was very, very effective. I think that continuing to educate the staff and spreading the word, and our in-services will also, like when they interview patients, they can also educate the patient and spread the word. They could spread it amongst their family so I think all of those things are important to continue doing in our huddles and our meetings as well. That will continue to spread the word in other ways.
Chad?
I just want to say, I'm very thankful to be here today. It warms my heart to be on a panel with other people who are doing the same thing and hearing about the same work that they're doing. It gets kind of lonely sometimes when you're I don't know, you feel like you're the only one fighting these battles, and it's good to know that we're not. And I'm very proud of the work we've done over the last 10 years. New York State really has been ahead of the curve. I think that New York State has a lot to be proud of. And while our numbers are not perfect, and I don't like to use relativism to make us feel better, but we're doing better than a lot of states. And I think it's a testament to what we've built here and the people that have built it.
Powerful. Thank you. Jen, any last words?
So while we do have a robust communication directly to our individuals, we do wrap around that with our trusted community partners. So, thinking about community-based organizations, faith-based organizations, we do a lot of events with them, and we thread that research message throughout. So maybe there is a community event based on healthy foods, right? But then we're talking about healthy foods, but then we'll say, hey, did you know that, renewals have started? Don't forget about this. So, someone in Montefiore is just making sure folks continue to be aware. We also wrap around that with partnering with our providers. They have their own, like Montefiore had said, their own direct research outreach, right? So we are here as a health plan to support them in that, right? What are some of the tools or, educational sessions we can provide their staff to let them know about renewals? We've been doing a lot of that. So we do think that having that wraparound strategy has been helpful for us.
So I know we're out of time. I want to thank our panelists. I really appreciate it. You guys were awesome. And thanks for everyone out there doing the same work that aren't on the panel. We could never do this without you. And this is why things are going as well as they are, in my opinion, anyway. Yeah. Thank you.
And thank you, Gabby, for your work. All right, I'll ask Sonia to come up so we can learn about the data. Thank you, Chad and Wen.
Good to see you all today. I'm going to be going over the data, and I apologize. I think I've gone through this in a number of different venues, so it might be a repeat for some of you with some updates. So as Amir said, just want to emphasize the point that this is a snapshot of point in time. It's a point in time data that aligns with what we submitted to CMS, and what we try to do in these dashboards that we're releasing each month is to put it in context. So CMS wants us to report it a certain way. So our data is apples to apples with what other states are reporting. But we know that every state is slightly different. And so what we try to do in this dashboard is put the CMS submission in context, given the structure of our marketplace and just how we're approaching the unwind process in general. And I'll just note that every dashboard, we are trying to make improvements. We've added new elements in the current dashboard, and based on the feedback we've received from folks, and we'll continue to try to make improvements and clarifications as we go along. So I'll start with the June cohort. So the June cohort size was 558,923. And that's both across the New York State of Health and through the local districts. And overall, our renewal rate in June was 72%. And the renewal completion rate was 70% through the New York State of Health and 82% through the local districts. And there's a bit of a caveat there because it's a little bit higher because of our mitigation plans, which I will let Lisa go into detail on. And, as we've pointed out, we do feel like we're above the national average on renewal completion, and we have a good view of that given our fully integrated marketplace. So we have a better view into where people end up. And the renewal rates for program breakdown this way for June. So renewal completion for the Medicaid population was 72%. 77% for the Child Health Plus population. And as you've read, I'm sure in the news, there is a focus on children being renewed. And I think we're pretty proud in New York that we have a very high rate of children completing their renewal. And slightly lower in the essential plan, 69%. And, part of this might be that as we go higher up on the income scale, that more people might be migrating into employer-sponsored coverage or not needing coverage anymore for a number of reasons. So here are a few more highlights from the June data. So as I said before, we're pretty proud that we have a high rate of renewal among children, 78%. The groups that we're lagging in are young adults, which this isn't really new for us. When we've looked at the data in the past, we've seen that young adults often wait till the either last minute to enroll or need to be prodded. Additionally, one way we're addressing this, which I think Amir noted in his keynote over the summer, is that every month based on this data, we slightly try to modify our digital ad placement strategy almost at a zip code level. So we are using this data to kind of shift our strategy from month to month. Another highlight from this slide is that we do see slightly lower renewal completion rates among certain communities of color and certain populations that prefer a language other than English. So we continue to look at ways to improve our outreach, advertising to those communities. This slide covers coverage transition. So again, New York is, I think, one of a few states where we're able to actually have insight into where people are migrating among state administered programs. So most members end up staying in the program they started out in. So here you'll see that 86% of individuals who were in Child Health Plus stay there, slightly lower in Essential Plan, 71%, and then back up in Medicaid, it's about 83%. So what this data doesn't capture are individuals who are transitioning to employer-sponsored coverage or have moved out of state or other things like that. And then one thing we added in our July dashboard that we published last Monday is an update on the June data. So as we've noted, members do have an opportunity to come in for late renewal, but that's sort of after we submitted our CMS report. So what we see in this data is very promising, and we hope this trend continues. But our overall renewal rate, when you take into account late renewal, jumps from 72% to 78%. And that's only informed by the data on New York State of Health, but that bolsters our overall number. And then when you kind of break down, so when you look at the CMS submission, it looks like 338,000 people have disenrolled from Medicaid and CHIP, both for procedural reasons or because they're no longer eligible for those programs. Now, we subtract from that 338,000 the late renewal population, and we get down to, it's about 311,000. That's just Medicaid and CHIP. And out of that group, we have, is a lot of numbers, 83,000 that were determined eligible for the essential plan and or qualified health plans and actually enrolled in that coverage. And I'll just say that it's mostly essential plan that people are moving into, and a much smaller number that are moving into qualified health plans. So at the end of it, we're left with 228,000 who are now no longer enrolled in coverage through the New York State of Health. And we know there are a number of reasons why people might not be enrolled that makes sense. They may have migrated to other types of coverage. They may have left the state. But we're going to continue to dig into this and try to figure out, where people are and who we're really missing that still needs coverage. And then this next slide starts to cover our July cohort highlights. And I added here, I know Anne went through this. We added in this version both call center metrics. We also added enrollment by renewal completion by county. So in our July cohort, we had 613,685 individuals And the overall renewal completion rate was slightly lower, 69%. So the rate on New York State of Health is 68%, and through the local districts is 73%. The rates by program are 69% on Medicaid, 76% on Child Health Plus, and 67% on Essential Plan. And I'll just note that while those are all lower, given the overall lower renewal completion, it's sort of in line with last month's trend. And then another important or interesting point that CMS is particularly interested in is the ex parte or administrative renewal rates. So they are relatively similar. So it was 41% in July versus 42% in June. And here, the trends are very similar. We're still seeing some populations where there are lower renewal completion. So it's typically young adults, communities of color, certain communities of color, because there are communities where we're seeing actually much higher renewal completion, as well as communities that have a limited English proficiency, have preferred a language other than English. And the coverage transition data is nearly identical to June, which we would hope and expect. So the majority of individuals end up staying in the program that they were eligible for when the renewal process started. A little bit more transition among the essential plan population. So as I said before, this is just a keynote about the data. Due to late renewals, retro coverage, the data is going to continue to change. We're going to continue to monitor it and share information as we can. And I know there have been a number of questions about options to look at other data sources to track where people are ending up. And so we're actively looking at that, both with administrative data sources and survey data sources. So we hope as we sort of bring it all together that we'll have more information and we'll be able to refine some of the projections we shared earlier this year at the first meeting. So hoping to come out with more information on that as we come to know more information. One interesting thing that we did, sort of in line with the many text messages that we are sending members, we added one to the list, which was a 1-question survey. And I've been told, it has been emphasized to me that we cannot extrapolate the results of this because there are a lot of factors around why someone would even respond to the survey. But I think the intent, with 2 intents with this text survey. One was to give people one more shot, one more reminder that they need to come back and renew. And the second was to get at least some insight into why someone may not have renewed their coverage or finished their renewal. So these were the reasons that we came up with. We worked with a research organization, SHADAC, to sort of refine the options. So one was coverage was too expensive. I have other coverage. The process was too hard. I haven't renewed yet, but I still want to help. And we're still sort of trying to make sense of the actual responses that people sent back, because I learned that people can text you back anything. So it takes some time to sort of go through all of it and make sense of it. But we got a pretty high response rate compared to some of our other texts. We got a 13% response, and 7% of the accounts that we texted came back and completed their renewal, even if they didn't respond to the text. So we know that just pinging people one more time does actually make a difference. And, we don't have the exact, we want to look at the trends of this month over month before we draw any conclusions, but people do indicate sometimes that they have other coverage, but many of the responses we received were from people who wanted help. So we ended up doing outreach through a call center, calling them back. if they needed help. And we're able to successfully renew many people through this. So this is just a little sample of some of what we're doing from a data perspective, but I'm happy to take any questions.
Folks online, don't forget to type your questions into the Q&A box, and we'll start here in the audience.
Great, thank you for that. It's clear that there are thousands of people working across the state getting folks engaged and recertified. In your data, do you have a sense of like how many touch points it takes to get someone recertified?
That's a really good question. I don't have that, but that is something that I think we should look at. Thankfully, because we are, I think you'll hear from Lisa, exercising every possible flexibility that CMS is offering us to administratively renew people. And so they don't need to do anything, a no-touch renewal, but yes, we should follow up and look into that. How many touch points makes a difference?
Yeah, and I'd also recommend looking at like which touch points tend to have the fewest engagements before you get someone recertified. Because that way, you know, the question is, do we keep doing what we're doing, or do we reallocate some resources to where we're seeing the greatest yield?
Definitely. And we are looking at our different text messages and emails to see which of them most likely triggers a renewal. So we have done that with our text messages. Our emails are a little bit mixed. When you send an email to someone that says, here's an important notice, they'll open it and they might take action based on that. But if we're like, get ready to renew, those ones seem to be ignored more. So we're trying to figure out how much to invest in refining email, for example, versus timing our text messages that in a way that gets people to act. But that's very helpful. We should dig into that more.
Thank you. Anthony Thompson here with UBO Health. And in our work with the federally qualified health centers, kind of dovetailing off the question that was mentioned earlier, do we have a sense of the sites where renewals are most completed? One perspective that may just be a legacy perspective, but I would love to dig into further, is that renewal at the site of care is probably the highest efficient point of touch, and how better can we work to continue to support presenting opportunities for recertification while members are coming in to receive the care?
So we definitely have data on renewals completed by certified assister by organization. So Gabby's and her team have been good about looking at that data and sort of prompting or having follow-up conversations with the sister organizations where we see it lower, and providers are included in that total. So that is something that we're looking at. I think that makes a ton of sense. And we've heard federally qualified health centers and others who have sort of a process of when a patient comes in, they ask them this question and they have someone right there to help them. And I think the issue is like, we don't know if everyone is actually going to get healthcare. So I don't know if that's necessarily that data point is going to make sense in that context, unless we're able to narrow it down to people who are seeking care around the time they need to renew. So I think that's the one challenge with that.
One from online, somebody looking deeply at the data. Can you explain the big difference in June and July renewals, the 14 versus 76% for people 65 plus?
So I think 65 plus is a little bit complicated. And I think every month we have tried to make it a little clearer, but on New York State of Health, due to one of the waivers that we've gotten from CMS, people who are 65 plus have more time to complete their renewal. And so they've been extended, is it 4 months? Right. So I think that's part of the difference. The other difference is that this month's report includes local district data, whereas last month's didn't. So that's, I think there are 4 panels on that page of the dashboard. So there's one that's New York State of Health. So that's the one you would want to compare to last month. And this month and going forward, we'll have all systems included.
Hi, just a question on your June data. So the 228,000 that no longer are eligible, does that number include people who are eligible but haven't come back? So what is the number in June for the people who were eligible to be renewed? Yes, some of them are gone, but from the existing information, or based on your history or policies or expectations, what proportion of that do you think are those that should have come back for or are administratively trapped? Is there a sense, just given your past work and your policy conversations, what proportion of that 228 are, should have come back, and what portion you think should have went on and got other stuff outside?
So that's a really good question. I think if you look back at what we presented in our February slide deck, I think at that time we were estimating perhaps a retention rate of about 80%, I think, right? Lisa, I'd have to double check that, but we're at 78%, right? When you look back at June, so we're pretty close to that. I think we still, like I said before, need to look at all these administrative data sources, like what we can know about who's in employer-sponsored coverage and these other factors, and kind of revisit those estimates we shared with you all in February to see, are we sort of okay? Like, are these people really, I mean, we continue to do outreach, as you know, but should we accept that to some extent? I think that's something we need to still look at and dig into the data for that.
Hi, my name is Laura Kamova. I'm an independent health policy and strategy analyst. Terrific data. Thank you so much for releasing it. The breakdown for languages, I think it's very interesting. Basically, which the data says that the people speaking Chinese will percent of renewal is 88% compared to 70% for the average population. Besides having support language lines and customer service that speak Mandarin and Cantonese, what other strategies are there to use and that can possibly be transferred to reach out populations that have much lower renewal rate? For example, people that speak Hindi have 56% renewal rate. Thank you.
That's a great question, and I'll tap others to chime in. I think we have great partnerships with communities. We have some staff that speak Mandarin and other languages, and I think that's helped a lot. I think another area that we've been exploring, and you may have seen this in our presentation in February, is around just community engagement and empowering trusted partners in communities within, they don't need to know, they don't need to be navigators. They don't need to be experts on the enrollment process, but they need to at least know enough information to be able to direct people. And so that's something we continue to build out through this process. We did a number of community dialogues where we got feedback on how we could facilitate that sort of empowerment within trusted community leaders. And we are sort of in the process of putting a lot of those findings into, putting them into work and in the field. So anything else, Danielle or Lisa?
I agree with everything else said. So I agree with everything Sonia said. But I think the only other things I would add, we have
a longstanding partnership with New Tang Dynasty, who we've been doing a lot of, events with over time. We advertise, we've been advertising for years in Chinese and Spanish. But I think something Jen said at the earlier panel about this idea of wrapping around with trusted community partners, and this what Sonia was just saying, is what we want to do more of. If this is being heard, consumers are hearing this from people they trust, and then they can follow up with the experts. I think, everything all comes together. So we do need to do better in other communities. We know that, more work.
Yeah, just to add on to that, we found a lot of greater success at Metro Plus with partnering with providers and CBOs and the Navigate organization. Because some of the data at the FQHCs may be skewed because we're all reaching out to the same people. So the same people that's on your list for either a Navigate organization or a hospital, they're on our list, the health plans. And so we're outreaching to them as well. So we have begun a lot of work with providers and a few navigators, but I'm open at Metro Plus to work with more navigators, more providers that are part of our network so that we can wrap our services all around together. I really think that would be a great way to capture people in a trifecta way.
One more question from online, and then we'll give Rachel in the room the last in-person question. Are you able to track data on immigrants, especially those that were previously on Essential Plan or Medicaid and are now losing either EP or Medicaid, and particularly immigrants that might have been frugal status?
Yeah, I guess at a raw level, we can track specific immigrant populations and by status. But we can't, for example, what is more difficult, and I think what a lot of people are trying to track is sort of what's happening with asylum seekers. And it's really hard to say someone with X status is a asylum seeker, therefore, and this is what's happening to them. I think we don't know that explicitly, but we could say that people who have X status, we could do renewal rates by different immigrant categories, technically. Mm-hmm.
There's another trusted source that you found some problems to rely on. And go to them more than they can go to their primary, to the dental providers, the vision providers, the pharmacists, all the ancillary services.
I had planned to ask about the increased nuance you had said that communities of color lagged. And then you qualified that saying that there were some differences.
Mm-hmm.
I plan to ask more about how disaggregated you can get the data with regard to both ethnic groups and geography. So with that question in mind, this whole last conversation makes me realize that, while you have 14 months or something for the federal government, this doesn't end in 14 months.
Mm-hmm.
So what can we learn about the communities that are lacking through this entire data-rich and touchpoint process? So you really have a list of target communities for further enrollment efforts ongoing. So it's a real learning opportunity for targeted outreach in the future as well.
And we're definitely tracking, that's a really good point. And we're tracking the data at sort of a zip code level by demographic categories. Sort of what we're using for digital ad placement, I think, is super informative just in general about who we're missing. And a lot of the work that I-Corps did with us that we shared in February was driven by that. So we posted actually on our website zip code level data around who's enrolled, and they helped overlay on top of that data other economic indicators that kind of helped us figure out which populations are and which neighborhoods, for example, in New York City are more vulnerable in this context, not just because language is a barrier, but because internet access is a barrier or other factors. So I think we continue to sort of dig into these issues.
Thank you so much, Sonia. And I've shared this with you, but I will share this with the group. our friends at the Center on Children and Families at Georgetown, when New York's data first came out, said that New York clearly had won the data transparency competition. So thank you for all that you've done. We all know how tough they can be there at CCF. So clearly, yet one more place where New York is leading the nation. So thank you.
All right. So I am going to be uncharacteristically brief today. I have two slides. One that you're seeing right now on our mitigation strategies. And we wanted to just make folks aware of this. CMS, the slides will be sent out. If you don't already have them, they will be sent to you. And there's a link on this slide at the bottom that is to CMS's website. And I think it was about 2 weeks ago, maybe 3 weeks ago now, CMS posted mitigation strategies for all of the states. And this slide is what we have in New York. And the reason we wanted to make you aware of it is that it impacts some of the data, and it impacts especially some of the questions that Sonia got around differences between data in New York State of Health and in the districts. So you'll see here that we have two areas where we were found non-compliant. And those areas of non-compliance are specifically due to WMS, which the welfare management system, which I'm sure all of you are aware of, and that's our legacy system. So that is the system that all of the local districts utilize. And that system was built in the 1970s. Before these rules came into place. And New York State of Health was actually built to be able to correctly administer these rules. And what the rules require, you'll see the first one is ex parte renewals. So what that means is that individuals should be renewed based on data sources. And if we can't renew an individual based on data sources, then we send them a renewal and ask for them to come back and give us updated information. So in the districts, we're not able to do that. In the districts, we actually send out a form to individuals and we ask them to attest to their information. So they don't necessarily have to provide information, but they have to send the form back telling us that they agree with what is in their file. So that's actually backwards from the CMS requirement. And then the second issue that we have with WMS is in terms of modalities for the renewal forms. So that's what you'll see as the second issue here. And the renewals are supposed to be accepted online, in person, by phone. And I'm missing one. There's 4. Fax. I'm looking at my brain trust over here. Mail. Thank you. By mail. All right. So we got by mail, we got online, we got by phone and in person. Thank you. I'm going to call out to my team over here. So in the districts, we have in person generally and by mail. But what we didn't have was online, and we don't have by phone. So HRA worked really hard during the public health emergency to update Access HRA to accept online renewals. And it was really great. I think I heard someone on the panel mention that has been a really good add. So that was really an impressive work during the public health emergency when everyone was short-staffed, and also really timely, because at the time HRA was doing this, we didn't know that the Consolidated Appropriations Act was going to require us to be in compliance with all of these rules. So that's the federal act that was passed last December, and it requires all of our systems to be in compliance. So the other thing that was really good was on the rest of state side. IES, the integrated eligibility system, had already worked on a mobile application for the districts in the rest of the state. And those districts are utilizing a mobile app where someone can, similarly to the New York State of Health app, you can take a photo of your documents or your renewal form and upload it that way. So those are the two ways we were able to come into compliance. We are still not in compliance with phone because we don't have a centralized call center like New York State of Health. But the way we were able to overcome that was to really work very hard with many of you in the room. And thank you so much to health plans, to navigators, to assisters for helping us meet that modality with all of your good work. So we truly appreciate that partnership. So the way we overcame the first issue, which is ex parte renewals, is with this complicated chart, this very dense chart. So we are not the winner in the number of E14s, but we're very close. We have 10 of them. I think the leader has 12. So, so as somebody said, we have basically taken every opportunity to improve how we meet consumer needs. And the first one we're really excited about, this is one that you haven't heard of before because we didn't have it the last time we met, which is 100% of the poverty line. And this is actually for New York State of Health because the ex parte requirement is that the person have income that's less than 100% based on data sources. So again, unfortunately in WMS, we don't have the ability to do that. We are looking at potentially being able to do that in WMS, but that's a really big lift and we're not sure if we're going to get there. But for New York State of Health, that's going to help a lot of people. And I think you saw in the slides that Sonia showed, Sonia, keep me honest here, is it 44% admin renewal? 41% admin renewal in New York State of Health, and we're anticipating that that number will increase based on this new addition. So the others, I'm not going to go through all of them. I'm going to skip down to 5 because that's really important. And I was so delighted to hear one of the assisters mention that they're seeing individuals in the age blind disabled categories reporting that they've been administratively renewed based on SNAP. So this was not originally how the E14 was offered to states. It was again offered with the concept of being able to hit up against a data source and kind of know where the person was in eligibility. And we're not able to do that because SNAP, like Medicaid, is in our legacy system and it's really difficult to get data out of it. So with some creativity with our federal partners, we came up with a solution that allowed us to disregard income from 138% of the poverty level, which is our new income level threshold for individuals over 65 and with disabilities. And the SNAP level goes to 200%. So we disregarded the income between 138 and 200% so that when we go out to the data source, all we have to do is see that the person is eligible for SNAP. And if they're eligible for SNAP, they're now eligible for Medicaid. And one of the really cool things that CMS did in this regard was to eliminate the household differences. So normally with SNAP, the household is based on who you prepare food with, unlike Medicaid, which is the household members that you're responsible for. So because of those differences in the past, we have been unable to use SNAP as an entry point for Medicaid. So that was a really significant change and one that we hope will continue, past the unwind. So that one I wanted to point out. And then another one I wanted to point out was number 8. We eliminated the resource test for individuals who are over 65 and with disabilities, again, because to try to streamline this process in the districts. So now when someone comes back to the district, the only thing that the district has to look at is income. They no longer have to do the resource test, which was burdensome with the verification system that was often had a 10 or so day delay. So that is not in place for the Unwind. And then the number 10 was the other one that I wanted to point out for the districts. This is also really important. And again, working together with CMS, we got to this one. So this allows individuals on fixed incomes. So, static Social Security income, not SSI, that's different. The Social Security retirement that I'm talking about here, or disability benefits, or pension benefits. Those individuals, if they have a month over month, the same income source, we can also administratively renew them without going out to data. So that was another good enhancement for the districts. And then actually, I should also talk about number 9. I know I said I would be brief. I'm never brief, those of you who know me well. So number 9 is also a really important benefit because, as many of you know, we have been working through the Unwind to document what's needed to build a new eligibility system for individuals in these categories. They're called non-MAGI. And in order to do that, we have been maintaining individuals in New York State of Health the entire time as they either turned 65 or gained Medicare. So our goal here was to not send individuals to WMS only to be sent a few years later back to a new system, but rather to keep them in New York State of Health where they will eventually end up. So that is a benefit, not just to consumers, but also to the districts. So over the public health emergency, that's now more than 100,000 people who don't have to go to districts during the Unwind. So at renewal, those individuals are renewed back into New York State of Health. We don't administer the resource test because, remember, the resource test is waived. So it's a really streamlined eligibility experience for them as well. So I'm going to stop there because many of you have heard all the others before. And we're going to actually move into a discussion period now. So if you have questions for me, I will take them. But we'll move into a general discussion of really anything that you all would like either us to hear. We're really hoping that you'll tell us, what we're doing well, which is nice, but more importantly, what you think we could be doing better.
Thanks so much, Lisa. I'll ask Danielle and the team to come up front. I will get the camera on you instead of me. And just for folks online, we've given the state team all the questions that were online from this morning. And then I am right now handing Danielle all the questions that are coming in live. So look forward to the discussion.
Great, thank you. It's always so wonderful being with you guys and talking about all this together, and we learn new things. And so that is the goal. We wanted to share more from February on exactly what we're doing. And you heard a lot of new things from customer service and from that wonderful panel of enrollment assisters. But this always gets the conversation going, and that is the point. We want to hear from you all on what we could be doing better. So I know there's questions, but I want to tee up a few others. The conversation started earlier around different ways we could be reaching a limited English population. I think Sonia flagged in the data another group that's been harder for us to reach are young adults. So we would just really love to hear from you on some ideas on what else we could be doing to reach those communities. And then the other point I want to put out there for you all to be thinking about is on people who leave our programs and may gain other coverage. We keep getting asked how to get at that information in real time. We know survey data will eventually catch up, but we want to try to capture those numbers in an as informed way as possible. So we'd love your thinking on that too. So I will start with those and then am I reading off the questions?
That's up to you.
Okay.
Your call.
I don't know if people want to start with those while I go through this list that's coming in real time. So, and are we walking around with the mic?
Yep.
Okay, great. Okay, let's do that.
Just to ask a question, was there anything set up in the state where, based on prior research that you've done, is there a panel or a set of people you could follow longitudinally to see what proportion of them, even just to get a sense of what proportion of them are eligible to be signed in, what proportion of them are expected to fall off, what proportion of them are expected to be aged out of. Over time, has there been any kind of research that has tracked these people and maybe can track them further through the unwinding process?
So you mean like actual people that we're following? So
Either a panel or a sample or
Mhm.
anything that is, does the state have any such process in place at all?
No, I don't, not that I'm aware of that we're following. I think to the extent that we're following cohorts, it's sort of baked into the administrative data that we use to project enrollment. So in those projections is reflected the attrition of various populations, and we're able to get to it by certain categories of people. But we haven't, to my knowledge, we haven't had like a concerted research effort following, the June 30th, 2023 population through time. But I think that's something we've talked about in the past and we should sort of revisit that.
And so that's the reason why there is still a problem estimating how many people are actually leaving the system and going off into.
Right. And I think the other issue is that the data that we have reflects a world we no longer live in, right? So we have a lot of administrative data on renewal processes pre-COVID, but so much has changed. So I think that is what we used to complete our projections. And that's sort of why now that we have approaching, 2 full cohorts, we need to go back to the estimates and revise them based on that experience.
Thank you. I want to agree with what Lisa had shared earlier, that you all have done an amazing job, and we are extremely fortunate as a state to have all of you leading this effort. I think, based on what you had shared, it seems like the no-touch, ex parte, automatic renewal solutions are working, and that can help reach underserved populations. To what extent, after the wind down, can some of these become permanent outside of having to go through the legislative process? And I think a second question I have is, from your perspective, what resources and staffing do you all need to expedite building out the New York State of Health to include the older adult population for Medicaid?
Yeah, so that's a great question. Fred, both of them are great. So the first one around the flexibilities we have currently and when they expire, we are advocating with our federal partners that these flexibilities extend until we are required to have a permanent solution in place from a compliance standpoint, which is currently scheduled for May of 2026. So we are asking and talking to them about extending between the end of the unwind to that 2026 time period. We don't have a definitive answer, but we believe that we're optimistic that CMS is seeing our results and paying attention to how impactful some of these changes are from a coverage standpoint. But that is going to be something we will not know the answer to until we get closer to the end, in all likelihood. From a resource standpoint, to get to the future state, I don't know necessarily that it's an internal staffing resource. It's a huge undertaking that will require investments both in our resources, but also in systems and IT. There's a lot of contingencies with things going on elsewhere. I think we're on a good path. We could always use more resources. But we're on a good path. It's just going to take some time. It's very complex, as Lisa laid out. There's a reason we have 10 plus E14 waivers, right? It's complicated. And so we want to do it thoughtfully. We have a phased in approach to get there. We're going to start with the easy stuff or the easier stuff, but we do feel like we can get there by 26, 27. Lisa, jump in if there's other. Lisa needs a lot more resources.
No, I agree with that. I think, you know, in terms of resources, that it is tough. You know, it's tough to get, it's tough to onboard people. The whole kind of process is hard. But in terms of getting to where we need to go with non-Magi, I think we did a really great job of utilizing the time that we had during the public health emergency, when we were always, you know, kind of like 1 foot in, 1 foot out. Is this going to end? Is it not going to end? And during that time, we really were able to dedicate not just our team, but, you know, teams around the state. We worked with different districts at looking at what the processes are like. We worked with Gabby's team and navigators and other assisters. So I think that we're in a good place to build that. So yeah.
All right, let me go to one that came in online, if that works. So this is a two-part, it's in the technology. I don't know that we're going to be able to answer part one, so I'm going to say them both. Part one is the use of technology for this process is great. However, we know all too well that many of our patients are not tech savvy, particularly individuals from our underserved and minority communities. We also know that limited data plans as well as limited internet access is also a barrier. How are these issues being addressed? That's the one I'm not sure we have answers to today. So let me go on and pose the next one, which I think we can tackle. And this is around texting. The person asks, are there templates that we can use for text messages that we can send on our own on our dashboards concerning renewals, address updates, doc requests, how to submit docs via the app, et cetera. And that one, I think we absolutely can tackle. But does anybody want to jump in with thoughts on either or both of those?
Well, I think on the first question, I think it's sort of what we talked about, trusted community leaders, community-based organizations are who we rely on to reach hard to reach populations. And, you know, almost 80% of Medicaid enrollees use an assister to enroll in coverage. So we know that, you know, through Gabby's team, that's the way to go. But we're continuing, as you know, someone else pointed out, there are certain populations where we're lagging. And so that's why we're trying to increase our outreach and building of partnerships with some of those communities.
Yeah, and just to piggyback on that, I mean, we have 370, I think, organizations, 5,000 plus people. And, you know, I think Chad hit on this so well this morning, like it's hearing that they helped me. Now, you know, you should go to them, they can help you. And building that relationship is in certain places so much more important than all the technology that we're trying to, you know, so hopefully a combination of both of those things, you know, the people that are tech savvy and can get a text and be like, oh yeah, I have to do this. And then the people that need multiple calls or explaining with someone that might have helped them in the past or someone they know helped in the past, I think is just invaluable. And I think it's just one of the great things that we have in New York.
Yeah, no, that's great. Let's see. Do we have anything in the room or should we keep going to the online? Laura?
Hi, I don't know if I'm in my.
It's coming.
Hi, Laura Castle, Medicaid Matters, New York. I have many questions and thankfully Fred asked one of them. I'm wondering, the panel that you had this morning on with all of the navigators from a variety of types of navigator programs was, I think, really telling and eye-opening in a lot of ways because it tells the story of their successes so far. And we all know that it's still very early in the process. There's going to be a story to tell through the entire process and into the future. But I'm wondering what else you all might be doing to tell the full story or a fuller story. And so a couple of thoughts I have. One, who else are you asking besides navigators and assisters? And I'm thinking about, the providers where people touch the system, not necessarily through navigators and assisters, pharmacies, et cetera, social services, legal services. Where do people touch services of any kind? Where maybe are they not touching services in the health and human services field, but maybe even outside of our usual health and human services, maybe, at schools, childcare, et cetera. What else can be done to fill out the story, to make it a more full story about what's happening? And then also, what, and I guess this is, it's partially related. What else are you doing to track what else is happening in the healthcare arena, particularly in Medicaid? And the biggest thing, excuse me, I think the biggest thing that comes to mind is the pharmacy transition. The pharmacy carve out has been mostly successful, but for some people it's been rocky, and that's been a pretty significant change to a major benefit in the Medicaid program. So that's one example of where there's a big sweeping change in the program that's happening at the same time. So thinking about what else is happening in the Medicaid environment and how that might be impacting the full story. Thanks.
Please.
So I'm glad you brought up the pharmacy carve out. Because one thing I think that we were really worried about was kind of the collision of the pharmacy carve out with the rollout or unwind of the continuous coverage requirement. And I think that some things you can only learn in hindsight. And at that time, I think we were really, very anxious about the unwind. But I think in actuality, that prepared members kind of very well for what was going to happen next. And, in terms of paying attention to mailings, making sure you understand what the change is and who to contact if you don't. And I think, our customer service line was really critical to that, and also has been taking kind of cross calls. So, we have a line for New York State of Health. We have what we used to call the statewide call center, which is, it's all run by the same contractor, but they're different kind of functions. So there's been a lot of cross-pollination from those two areas. And I think that was really instructive in kind of how we needed to build out so that we could respond appropriately to those calls.
And just to add to that, we were able to, I don't want to say test, but we started to leverage some of the flexibilities we have with member engagement. So text messaging and reaching members. The pharmacy transition was actually what we used first. And we approved upon that, obviously, when the continuous coverage requirement ended. But we also worked very closely with the pharmacy associations to include that upfront sort of outreach for members at the counter, at point of service, because we knew historically right? A lot of times people find out they're no longer covered when they show up at the pharmacy. So we were definitely concerned. I think it actually has proved to be helpful in terms of that transition. There's certainly more we can do for other aspects of the healthcare system. And we are looking at any and all data sources, even exclusive of Medicaid, to make sure we are tracking the ESI transitions to the greatest degree possible. But I think schools is a place we can do more, and I'm sure there's others, and we look forward to feedback on how to do that best.
Yeah, just one other piece on the pharmacy. It also led to, I think, a really positive outcome in terms of a rollout of a campaign around the Unwind. Marcy Goldstein, who many of you know is not with us today, but her team rolled out a whole public awareness campaign with pharmacies, so that, you know, on the bag that you get your medication in, it's, you know, talks about renewals. There's like fact sheets and stuff that can be on pharmacy counters. So there was a whole rollout that happened with pharmacists as a result.
Yeah, and schools, I mean, we can do back to school campaigns and backpack flyers and things like that. So I think the surround sound message that we keep hearing, and as long as people aren't sick of us, they'll keep getting it from lots of directions. Rachel, oh, sorry, go ahead, Peter.
It's me again. I start to notice with my enrollment with New York State of Health, people, when they apply for SNAP, their Medicaid transfer to HRA. How can we stop that from happening? When they apply for SNAP, they're already with the New York State of Health on Medicaid. Can they just apply for SNAP alone without transferring the Medicaid to HRA?
Yeah.
Because the application, they have different immigration status. The green card holders, they have to be an essential plan. HRA, they don't have essential plan. So
Right.
they closed the whole case on the family, not knowing what the immigration status. On the other hand, a couple of days ago, I had an application was created by HRA for a family with the New York State of Health. So they came to me to update their immigration status, their information. At what point these changes happening? So we need to communicate with HRA. There have to be communication between New York State of Health and HRA. They need to check when they apply for a SNAP. If they're already on Medicaid with the state, do not apply for Medicaid for them. It's creating lots of confusion for the families, lots of problems. I don't know what's the agenda. How can we do that? We would love to help.
Yeah, thank you for that, Maha. That is really good feedback for us. I'll take that back to our team because I'm not sure we were aware that that's happening. And I totally agree with you. If someone already has coverage through New York State of Health, they shouldn't have to lose it just because they've applied for a SNAP benefit. So we'll take that back to our team.
No.
Yeah, completely, totally agree with you. Yeah, so. Yeah, the other thing, if you wouldn't mind, if you could email me a couple of examples, that would be helpful, and for us to, yeah, because then we can track, we can kind of follow the trail and see where the breakdown is. Okay, yeah, so we'll take a look. Thank you.
Hi, this is Mari Vaz from Bronx Legal Services. I just wanted to say that that's not supposed to happen.
No.
Right.
Yeah, it's not.
They should only be moving to, or their Medicaid case should only move to HRA if they open a cash assistance case, but even with cash assistance, sometimes they can still keep their coverage at NYSOH. So hopefully those are just one-offs, but I'd love to talk to you more about it.
Hi, Rebecca Wallach from NYLAG. Thank you so much for the presentation today. I wanted to bring up another special population, duals with long-term supports and services, especially those who on NYSOH who became duals during the COVID pandemic, the 3 years while we had the pause. And then going forward, starting now with the Unwind, people who become duals, who have LTSS in their cases on NYSO. So these are people who can renew and be found eligible, but because of transitions between NYSO and WMS and the relationship with the plan, they might lose services. So I know that the state wants to keep, that this is a population that will move from NYSO to WMS, but there's really a lack of guidance about which populations are going to move when, who might stay, who might not stay. So I wanted to raise that to you here.
Yeah, thank you for that, Rebecca. And we are looking at this issue and trying to figure out, we're actually trying to figure out if we can maintain more cases on New York State of Health rather than move people. But there is a coordination issue with how the services are obtained. So yeah, but we are looking at that issue. We appreciate you raising it.
Hi, my name is Eliza Benyon from Metro Plus Health. I just want to know what your experience has been with the homeless population and what the recertification rate has been, if you are aware of that. From our experience, we're having a hard time identifying who our homeless members are based on the 834 file, as well as our public assistance members. And we want to make sure that they are recertifying. And because we're having a difficult time identifying who they are, what the recertification date is, and how we successfully recertified. I want to know what your experience has been overall on the homeless population. That was my first question. And my second question for Sonia is, I know that July you hit a 69% success rate. Were you surprised because July had an extra day, where June you had 72% and July you had 69%? And were you surprised that you had a lower success rate? And what
I think we were
disappointed.
disappointed, but I think it's still within the range, you know, it's not like so far off of, on New York State of Health, I think we were 68 versus 70%. So I don't think we felt like we were, you know, totally going down a path. And then as Lisa noted, we have some other admin renewal improvements that we're rolling out in the coming months. So I think we're not concerned yet. I think once we roll out all of those improvements, we want to look at the rate again because we want to make sure it's going up. So, and we only have 2 months of data, so I think we need to sort of give it a little time as we proceed. And on the,
Can I just add to that? So 2 things. One, it was a bigger cohort too in July. And then the second is, I think we keep saying that it was a snapshot in time.
Right.
And look at what the number in June was now that we have all the late renewals and it's actually 78. So I think we just have to be careful to not read too much into one piece of data at one point in time.
I mean, and just to add on to that, I think it would be concerning if we saw something abnormal as compared to the prior month, which we did not. It's the same age cohort that is not renewing at the rate we would hope and that we expect to be moving to ESI. So there's nothing concerning in comparing the 2 point-in-time snapshots that suggest we're not doing a better job. The numbers are only going to go up after we release them.
Okay. And then from the homeless.
yeah, I was gonna ask others, but I don't think we've been specifically tracking them. So I know that the way, I don't think we have a direct way of tracking the unhoused population. I think it's generally, we are aware of certain addresses that everybody uses. So I think the way we would track that is sort of gather those set addresses that we know are used by that population and track renewal rates that way. So I think that's something we can take back and look at.
Yeah, if we have an indicator somewhere that we could identify who the public assistants are versus homeless, that would be really helpful.
So I don't know if we could create an indicator, but I think that the address is sort of the proxy. So we would, I mean, and we could see if among Metro Plus's population, you might be able to identify there's, you know, a lot of people identifying with a particular address. I think that's, you know, that's the flag for you, but we can take that back to our team because I think they know the handful of addresses that are common.
Yeah, and I was gonna say, I think in our sister training, you know, way back, there are certain addresses that definitely are associated. So we can take those, you know, we'll go back and get those for you and you should be able to create something to see how you're doing with those addresses at least.
Right, I was wondering what the state was seeing too, in terms
Yeah,
of the
yeah.
renewal rate. Okay, thank you.
Hi, ask a question. Both Lisa and Anne, I think, talked about customer service. And I think that's so critical during this whole process. A lot of our members, health plan representatives call customer service lines to help navigate the system. NYSOH, we've seen really good success in getting navigation and questions answered. We do struggle a little bit with HRA, even scenarios where our members are recertifying on time in June and July, but then they get auto renewed for 4 months or the extension. They get sent another set of renewal forms, and I think the system just triggers that. And so when we call to say they've already recertified, so can they ignore the second mail? We don't get straight answers. And so, this is just one example. Even for the auto renewals of SNAP eligibility, we have members who never receive a renewal form. They're not able to access it. And so again, I think having that, it's great to hear there's constant refresher trainings of agents. But I think that is a problem we're seeing instead of inundating your mailboxes. If there's a way we can help, we try to track the rep's name, the date, the time of the calls. If there's a common mailbox that goes to, we'd love to see that. If that already exists, apologize. And then to Danielle's question about just what we can do to help, especially the culturally or linguistic populations, vulnerable populations, where you're seeing lower renewal rates. I was telling Sonia this earlier, wearing my former consumer advocacy hat. One thing that we notice is language lines are great, but they're very technical. They're going to answer it in a technical format. They're not always healthcare advocates by heart. So I think the importance of CBOs can't be, overstated. I think they play a critical role in this, and also having maybe testimonials from members who have successfully renewed and seeing familiar faces, people that they are familiar with, who they probably trust. I think getting in the door is really important. The application and renewal process, the technicality will follow, but you need to get people to trust and make that first step.
Great suggestion.
Yeah. So just in terms, Priya, thank you for that. In terms, I just want to explain a little bit about how the SNAP ex parte process works. So because of the timing, you're right, 2 renewal packages are going out, and they don't necessarily track perfectly. So what happens is if the original renewal packet goes out, we didn't have the automatic SNAP ex parte process in place until renewals that were associated with October 31st end dates. So because of that, that's why we did the 4-month extensions. So as part of the mitigation, we wanted to make sure that no one who had the benefit of going through the ex parte process was terminated for failure to respond to a renewal packet. So what is happening in that process is if someone, let's just take June, if they didn't respond to their June renewal, their case would be pushed out for 4 months. And because 4 months actually means that the cases were reviewed in July. In July is when the SNAP ex parte review was done. And at that point in time, someone could have been automatically renewed for that October 31st cohort. But this is way in the weeds, but because of the timing mechanisms, a renewal packet could also be sent.
Yeah.
And that's just really difficult to coordinate in WMS.
Yes, Priya, the other question I would have is when you're getting the roster, is that renewal date pushed out for that specific case, or is it still the old date? Okay. That's helpful. Yeah, this timing issue has also resulted in
First time, so
Yeah.
can they then ignore
send us.
the second?
Yeah,
Send us the,
you
send us.
yeah,
the
send
send-
us the cases,
Okay.
because I want
Is there a
to,
few?
yeah,
Yeah.
yeah, it's just send them to us so that we can take a look at them. Because again, it's really helpful to track back and see what's happening.
Okay.
Yeah, before we answer that.
We want to say yes.
And then we do want to say yes, but what we'll do is, we'll send an update out. We can send an update out to everyone who was on this after we have a chance to look at some cases.
That would be great.
Yeah.
I think that was one of the other questions on here, so.
Yes, it was.
Yeah, it is. Yeah.
So there were points made about surround sound, meaning saturating every means of communicating through touch points that exist. But at some point in the middle of this 14-month period of time, when the data becomes clear about your lagging populations, there really needs to be a shift to a high level of targeting, or at least blended with surround sound. And that requires, unfortunately, money, because you guys can't do the close, it's the CBO approach, which you know that some of the private funders on a very small scale have tried to help with. But when you get to the point that you know the populations that are lagging, whether it's homeless or it's particular neighborhoods or ethnicities or youth, young adults, you know, there are particular venues and particular trusted messengers and particular messages that may work better, that could be marshaled, but that requires a set of players that are not really funded to be doing that work. No, your sisters are not funded to do outreach, and there aren't additional networks and all the many different agencies that could be playing a part. So it's like when you become clearer on the data about the lagging populations, then it would be, I think, really important to figure out if there are any resources to add to the targeted, informed by the data outreach that has particular messages, particular agencies in particular neighborhoods that can reach those lagging populations. So it's a shift in, or a blended strategy, but a shift in priority once the data starts to tell you where your problems are.
So can we just make sure because I agree with you completely. We will, you know, hopefully every month get around an 80% once the data settle out. And we'll know who these lagging populations are. But when you say the resources, in addition to building this whole community of CBO partners that we will continue to build to be extending our messaging, and I think we can highly target our advertising into these communities, but do you mean more than that, I think? So can you say more about, in addition to those steps, what you think resources would need to be directed towards?
I mean, I think for each lagging population, there might be a slightly different answer to that. You know, if you were targeting young adults who have always been a lagging population in health insurance enrollment because they feel like their health and, you know, long before the ACA.
Sure, the invincible.
So that's, you know, that's a set of messages. It's a set of, you know, CUNY and SUNY partners. It's et cetera, et cetera. There's
Okay.
a particular, so if you ask me that immigrant groups, that would be yet a different, or homeless individuals. So the answer is slightly different.
Yep.
Yes, targeting means a
Got
really
it.
nuanced strategy, which is right now you are rightfully concentrating on the surround sound as much as you can do it to everybody.
Yeah.
Because you got to start there. But at some point the data should allow you to be much more targeted.
Yes.
Because the surround sound is going to get you only so far with some of these populations.
Yep. No, I think we're trying to do both, but we obviously need to do
I
more.
mean, yeah, you need a mini strategy for each of your lagging areas, and they'd be somewhat different.
Hi, just to add a little bit more to that suggestion, I don't believe you need to build a whole new network. There's been a whole public health effort about COVID response. And they, you know, local health departments and have engaged a lot of CBOs. There have been, you know, CDC funding. A lot of those efforts continue to be funded for outreach. Those are targeting CBOs, those are targeting specific neighborhoods, language groups, hard to reach populations. You just have to strengthen that relationship and work with whatever is already in place. You have terrific data, and I don't believe you need to wait to see who the lagging populations are. You kind of already have a feel for it. I think the biggest challenge will be, connecting with those networks that are already in place and the organizations that are doing work or have been doing the work, including enrolling a lot of those people that, were able to enroll during COVID.
Keep going. Okay, so we're gonna take a few more. And then there are a lot that have come in that I think we'll compile again and answer, right? We'll continue to post to our website. All right, there's a couple of process questions. I think we can answer this one. Has all the June recertification paperwork been processed, or is there a backlog of applications that still need to be processed? That's one. And then I'll just put another process one out there on return mail. This specific question is, where is a forwarding address? Sorry, on return mail, where there is a forwarding address, how is this handled? And anything else we want to say about return mail? So let's try to tackle those two.
Yeah, so I think for the first one,
The backlog.
yeah, the
Backlog.
I wouldn't
backlog.
call it a backlog.
Yeah, so there's a couple of different things happening in June. One are the mitigations that are happening in the districts. So that's not really a backlog, that's intentional. We're intentionally pushing out cases so that we follow the CMS guidance, which is to have the processes in place. So those aren't backlogs in the traditional sense of a backlog, which are cases that you can't get to. But another point on June is that June is going to change months out. It's going to continue to change, just like we saw the 1 month renewal. So we have a 1 month late renewal, which means no gap in health plan coverage. But also there's a Medicaid 3 month retroactive coverage, right? So that puts you, I always have to count it on my fingers. So for June, that's July, August, September, October. If someone applies in October, they can get back to have that coverage. It is true that it's not health plan coverage, it's fee for service coverage, but it's retroactive coverage. And then also there will be people who in months 5 and 6 are still coming back for whatever reason. It could be that they had a bounce in income and they were ineligible at that time, where they had employer sponsored coverage and then they lost it. So I think those June numbers are going to just continuously change, and we're going to be looking at them for the entire 12 months. So that's one thing I just caution on looking at the data. It's really volatile.
It is. The good news is that the number will only improve
That's right.
after we put it out.
That's
right. Mm-hmm.
But just one quick, so clarification.
Yeah. Right.
So just in terms of though, like, let's say somebody finishes their packet and sends it in, are there any so I know on the New York State of Health side, Anne said there are no backlogs in document processing. Do we have a response on HRA and upstate?
So, yeah, so we don't really, because of this pushing out
Because of
for
the
4
pushing out,
months.
exactly.
So that is just kind of impossible to.
Right, so we're extending people.
Because
yeah.
we're extending the
Right.
cases. Yeah.
And then on the return mail question, so on the New York State of Health side, we do check one of those USPS certified services that tells us about moved address, forwarding addresses. So anytime we send out a notice, we check that. And the way we handle it is we send people a notice to the forwarding address, but we also send sort of like when you get a change of address with your bank, they send you 2 notices, one to your old address, a new one, and says, if this is wrong, come back and tell us. So we do, and then we're also triggering a text message and an email. So like, we are really taking a lot of follow-up actions based on that information.
All right, we're being told we have to stop as much as we could go on. So we're gonna wrap and thank you all, but please keep sending your suggestions our way. And we will compile these and answer them and post to our website. So thank you for participating and for your engagement. This is truly a partnership. So we thank you all for your help and being here today.
And all your feedback. Thank you.
So before you all exit the room, let me just say a few words. I want to thank our partners at the state for taking time out of this crazy busy season to share with us in the spirit of transparency, the good, the bad, and the ugly about what we've all gone through. I want to thank you all for taking time out of your late August to come and be here in person as well as virtually. You know, this whole process reminds me of like the quintessential QI process where we plan, do, study, and act, right? So we've just gone through a QI cycle where there's been transparency about quantitative data. We've taken into account qualitative data, and we've shared examples of the way in which the system hasn't worked the way it was built or intended to, and nuances that we need to take into consideration to make it even stronger as it goes forward. And so I don't think I could have done that without sort of my UHF hat and having QI and bridging quality and equity be really one of our cornerstones. Because at the end of the day, you know, we're ending as we started with the individual as the focus, and how do we maximize the number of people that remain covered and have no interruption in care. So thank you all for being a part of this. And again, before you leave, I would be remiss if I didn't thank the UHF team that made it possible today. Many folks, Emily, Giovanna, Alex, Frank, Amy, Peter, Sam, Joey, Sharon, and of course, Chad, who is the other man of the hour. So thank you all. And I look forward to the next PDSA cycle. You guys tell us when and we'll get it together. All right. Thank you all. Have a great summer.